Welcome, everybody joining us on Facebook, LinkedIn, YouTube. It is 3 o'clock in the afternoon on April 18th, 2025. Happy Good Friday to those who celebrate. And today I am joined by Dr. Kenneth Taylor from Piedmont in Atlanta, Georgia. And we are excited because we are finishing the project and we are announcing that we have a brand new HCMA recognized Center of Excellence in our network. And I would like to introduce you all to Dr. Kenneth Taylor. Ken, welcome.
Thank you so much, Lisa. It's a pleasure to be here, and thank you for everything in this whole process.
So, you are very, very welcome, but I'm going to do a visual here. This little baby file that is in my hands is the application for your site, your institution to join the HCMA Recognized Center of Excellence program. And it is not a small task. And it started a long time ago. And we finally crossed the finish line. And I'd like you to tell our listeners and those who view this in the future why you were interested in HCM. And then we'll start talking about your center.
Sounds great. So thank you so much. My history in hypertrophic cardiomyopathy goes back a long time. It's actually my first stepping my toe into the water in cardiology. My mentor of blessed memory, Dr. Mark Silverman from Atlanta, Georgia, when I was a medical student, sent me to the NIH to do a couple of month rotation during my third and fourth year of medical school. And I had the great opportunity to work with this young cardiologist by the name of Barry Marin, who was doing work in hypertrophic disease at the NIH. And that was really my first clinical rotation in cardiology. And at that time, I was very excited about it. And I've always maintained that interest through all of my years of training. About probably 25 years ago, I was kind of the lone heart failure doctor at Piedmont, long before we had the program we have. And I was asked to help build a program there. So I built a multidisciplinary disease management program at Piedmont, which started with myself and one other physician and eventually grew to what is now a quaternary care VAD transplant program with very, very high numbers. And it's a full comprehensive heart failure program. So I kind of gave birth to that. And then once I gave birth to that, I decided we needed to do the same thing with hypertrophic disease. So I look back, I think I started working in this area more specifically about 10 to 12 years ago. I think that's when I gave my first presentation to Piedmont about the need for a hypertrophic center. It was around the same time as the guidelines had come out recommending centers for programs to develop. And so it's kind of been a slow process, and it led me probably about 8 years until I was ready to start officially going after HCMA COI. Center of Excellence certification.
And through that time, I would hear this name come out of Atlanta occasionally. I saw this guy named Dr. Taylor. I'm like, let's see what's going on. Oh, this is pretty good management. We didn't miss a trick. Okay. And then your name started to come up more in my circles when talking to other people. I'm like, okay. And then we finally meet and we get the ball rolling. And here we are today. So can you tell us what you've built and who's on your team?
Sure, yes. So I kind of followed the same model I did 25 years ago with the heart failure model in building a comprehensive multidisciplinary team for disease management. So this is disease management program as it relates to hypertrophic cardiomyopathy. And specifically, to really take care of this disease well, you need a lot of people. You need people from multiple subspecialties. And so I originally put together and have continued to maintain heart surgeons, interventional cardiologists, electrophysiologists, nurse practitioners, nurses, stress test, exercise physiologists, echocardiography people, imaging people, and kind of brought them all to the table together to initially build protocols And so my goal was to make sure that the basics of managing HCM were available to everybody, and that everybody knew what the bottom line was, what everybody should be doing at the kind of the lowest level. And so building protocols to help my colleagues know how best to manage this disease, and being available, of course, for consultation and for directing care, but to basically put out there to my community the tools with which my colleagues could then help manage this disease. And that was kind of our first step. And then subsequent to that, we then took that team and started building out more specific ways of identifying patients and bringing them in and making sure they're getting the best care possible.
How many people are on your team?
Oh, goodness.
I know, I asked a question and I have the answer here in front of me. And I'm going to go.
CT surgery, interventional cardiology, imaging, sports cardiology, 1, 2, 3, 4 heart HCM cardiologists, electrophysiology. Am I missing somebody? Those are the doctors.
Yeah, I think that's
9 or 10 physicians
yeah.
are the core, and then we obviously have a lot of other ancillary people who support that.
You also have the ability, because you have a larger network in Piedmont, you have facilities located throughout the state. Can you talk a little bit about that and what services for HCM might be available in some of those more remote areas?
Sure. So I believe, and I'm not an administrator, but I think Piedmont touches 85% of the state of Georgia. And so everywhere from the very, very northernmost part leading up to like Murphy, North Carolina, all the way down to Savannah, Columbus, we have specific HCM practitioners in 4 major locations: up in the mountains in the Blairsville area, out in Athens to the east, down south with Dr. Andrew Darlington, who's been instrumental in helping me build this. He's been my real major partner. He has great experience in HCM and has been a godsend to me to help build this. And then in what we call kind of the center in Atlanta. But we also do have the ability to reach out to further south locations. We also now have Augusta as a new spoke in the hub and spoke model.
So Georgia, at this point, might have to do a little bit more digging, but I think in terms of HCMA recognized centers of excellence, Georgia now is home to 3. And I do believe that just about the best coverage for HCM now exists in Georgia.
Awesome.
Congratulations.
Woo-hoo. Biggest airport, best HCMA coverage.
Not my favorite airport.
Sorry.
But an efficient one. Okay. Yeah. So Georgia, you guys work very nicely together there.
Yes.
And you know Robbie, and you met Dr. Burrows as well. So we have 3 real forward-thinking physicians in Georgia, and some of these families are going to have care in some programs and others, and insurance access issues might make one more accessible than another in terms of programs. Can you tell us a little bit about the ecosystem of HCM in Georgia and your part and these other organizations?
Yeah, so I actually started my practice 30 years ago out in what's now Wellstar land. So I started at Cobb Hospital and Paulding Hospital and Douglas Hospital. So I have a huge number of patients who I still take care of, and they get their primary care and some of their primary cardiology care out there, but they come to me for more specialty care, or they come to me for their cardiac care. So I have been interacting with the doctors out in Wellstar, and obviously Emory and Piedmont are side by side in Atlanta. And most of us have some tie there. I did go to medical school there, and the cardiology divisions are very commonly working hand in hand. So it is not uncommon. I think I told you one of my patients just got admitted to Emory Hospital, and Robbie called me, and we talked about how the patient was going to be managed, and I was completely comfortable knowing that my patient was in his hands. And so I think we are all very comfortable cooperating with each other, and it's actually pretty common for patients to go from one to the other. We have a big transplant program in multiple organs, and Wellstar doesn't. So it's not uncommon that we will get some of the transplant people sent to us. And I think there's a fair amount of cross pollination.
And I think that creates the best ecosystem for somebody with HCM to be in, because if they land in an emergency room, you have a system in place that you're going to get excellent care as long as we call that right HCM doc to get things moving.
Right.
So on the screen now, you can see the contact information to make an appointment with the HCMA program at Piedmont. And it's going to be in the directory listing as well. So I will flash this a couple of times as we go if anybody needs that contact information. So I will pop that back down for a second. It'll come back later. So what is it about HCM that at this point in your career, you're like, this needs to be fixed before I can, hand it over to the next generation? What is it about HCM that still has you intrigued all these years later?
That's a great question. So I got into cardiology in general because I love the anatomy. I love the physiology. I was both a heart failure physician and an interventionalist. So I spent 30 years in the cath lab. And to me, the cath lab is a hemodynamic lab. It's a physiology lab. And so I just love physiology. And HCM is a physiologic disease, particularly obstructive HCM. And so from just a purely scientific perspective, it really excites me. As far as management of the population, I have spent my career trying to build systems to help optimize care to larger communities of health in a population. The number of patients that I can personally touch is finite, but the number of patients I can touch by building a system is exponentially greater. And so if I can build a system that helps support other doctors and other practitioners to care for a group of patients, then I can have a greater impact. And my goal has been and will continue to be to make sure that patients have access to cutting edge therapies and the best guideline directed medical therapy that is out there. And we know, and we've known historically, that the Centers for Medicare Medicaid years ago described something called the quality chasm, that there's a big gap between what we know and what actually happens. And we can utilize things like guidelines and programs that utilize those guidelines to help provide care to narrow that gap, to make sure that more people have access to proven therapies than are currently getting them. So my goal has been to, going back to HCM, I feel like that's one of the diseases left that has a lot of potential for benefit, a lot of room to be able to get a group of people access to better care.
I think you articulated that very nicely, and it goes into core concepts of what we believe in as an organization. There's very specific language we use in our recognition process, and it is recognition, not accreditation, not certification. We know the services that the patient needs, the quality that is available with some work and system creation, and the emotional needs and the non-cardiac needs of the patient. And we want to make sure that we're partnering with people who can share that vision of systemizing medicine while making it personal.
Right.
There's so many things that if the systems work, it's just easier for everybody in the system. My internal team knows how I feel about creating processes and systems, because that's how we grow, and that's how you can manage growth and take care of more people by having really good refined systems. So kudos to that. And it's probably why we get along so good, because we think about systems. What system is broken and how can we fix it and what do we need to do? But I kind of love how this all comes to, full circle, because your mentor was one of my mentor's mentors.
Yep.
Go figure that one out. So Carolyn Biro, the founder of Cardiomyopathy UK, as it's now known, was really good friends with Mark.
Mark, yeah.
And
he spent
like,
a lot of time studying Sir William Osler and wrote a book about him, and took a sabbatical and went to England and researched and wrote a book on Osler.
Really?
Yeah, I can get you a copy if you want it. I think I still have it.
Yes, please.
Yeah. He was very into medical history, and so, in fact, when he was still alive, I managed his practice while he went to England and took a sabbatical and wrote his book.
I have the book in the other room and it's signed.
Oh, okay. Sorry.
I should have brought that book with me. He sent it to me after I had met him, and Carolyn and he and I had talked, and he was not as instrumental in the early days as, Barry, Harry, Bill, and Cricket were, but he was in the background.
Yeah.
So it's kind of interesting how it's come full circle again. And he was a great teacher.
I remember him showing me systolic anterior motion of the mitral valve by M-mode echo when I was a medical student.
For those patients who are currently watching this, M-mode was this early echo. That's all you had. And it looked like the way, like if you saw a fish finder, it kind of looks like a fish finder. And
we still use it, by the way.
I know we still do use it, but patients don't connect with it because they get the beating images of the heart or 3D images of the heart, and they see that. My first echo obviously was M mode, and the lady was trying to explain to me at 12 years old what the spaces were and where the lines were and what they meant. And I'm like, you gotta make this better because it's too confusing. Yeah. But knowing how to read an M mode is kind of masterclass these days, I think. Yeah. Young ones don't learn it so much.
Yes. Well, actually, it's part of the boards. There are board questions that include M mode.
Okay, well, that's good. I like that.
Freco boards.
Okay. So they got to know it.
Yeah.
I don't think they use it very much, but they got to know it. So you have a team of both earlier career and later career individuals, and you're all over the state. How are you coordinating the patient meeting? Are you doing a weekly, monthly, quarterly? How often are you meeting as a team?
Right now, it's kind of monthly to quarterly, depending on kind of people's availability. We use it mostly for, presenting interesting cases to the group. We have a lot of collaboration, though. So if one of my partners in another place has an issue, we pick up the phone and we talk to each other. We're all in the same medical record, so we can send epic notes. So I have, one doctor in one area who regularly sends me, an epic note saying, "Hey, look at this case. Tell me what you think about the echo. Tell me what we should do about this." And I'll send notes to some of my colleagues. "Hey, I've got a patient who lives out near you. Can you take care of them?" And when I'm available if need be. So we have a lot of communication on a daily basis, and then we try to put together group lead meetings, probably quarterly right now.
And how many patients are you currently following with HCM at this point? I don't remember what the numbers
You might have better numbers than I. I know personally, I think I'm in, actually, I'm not sure I can answer that question. It's a little complicated because we have patients who are seen by other cardiologists, and then they come to see me, and then there are patients who I'm their primary cardiologist. I know in our system, we have in the several thousand range. I think myself personally, I'm in the probably 300 or 400 range.
Yeah, I was gonna say, I think you were around the 400 mark as an individual provider and through the program, but system-wide, there's many more that we still have to go in and clean.
And actually, I think there's also a huge number that have not been touched by either a cardiologist or an HCM cardiologist. So there's a lot of opportunity out there.
So one of the things that we've been doing with all of our new up and coming programs is, this is more for the community than for you, Ken, is asking them not only to look within the HCM program in their hospital, but look system-wide, how many diagnostic codes for HCM live in the system. And many of those individuals are not really aware of their diagnostic status because it was an incidental finding and somebody didn't want to make a big deal out of it. So they kind of wait for somebody to complain and then they come up with it. This is not a Piedmont issue. This is
Yeah.
just US healthcare.
Yeah.
So we do need to engage those patients, bring them in, make sure their families are getting screened and that they have the knowledge that they have an underlying structural heart disease. So the diagnosis is critical, and then we can get them onto the proper treatments.
Right.
So you're offering medical management, device management, up to and including transplant. Is there anything that you don't offer? I don't think so.
No, I don't think so. We're soup to nuts. We got the whole thing. I will say, data and identifying patients is a challenge in medicine, and especially in HCM. And it's a challenge that we are trying to address. And I know our other programs in the area are having the same issue. There's a fair amount of noise when you start looking at a population, because you'll get a lot of people who actually don't have HCM. They have hypertension and they have a little LVH from it. And you'll have people who have HCM and have not been coded correctly. So one of the next projects that we're doing, and I think we will do it in cooperation with at least one, if not two of the other centers in our area, is to try to help build a database and utilize that database to try to help tease out the noise and identify those patients who need to be brought into the program and those that don't need to be.
Well, that's an exciting project, and we definitely look forward to seeing how you develop that. And of course, we'll be happy to be a partner in that as well. So again, I'm bringing up your contact information. If they're going to call to schedule here, are they able to schedule with a different location?
Yes. They just need to mention that they would like one of our HCM providers. Right now we have kind of 5 major areas: Augusta, south side, which is kind of Sharpsburg, Fayetteville, Noonan area, Athens, Blairsville, North Georgia, and then central Atlanta. And it's all, we have a pretty robust website, and I think it's down there for more, piedmont.org/HCM. And so all of our practitioners and all of our information and all of our everything we've done is on that, including some educational videos for patients and physicians.
They did a nice job on their website. So yes, go take a look at that resource and schedule an appointment if you're in the area and you're looking for care. Look at your health systems, look at your insurance, see where you're covered. You have awesome choices in Georgia right now. What's the wait time to get an appointment at this point?
It depends on the urgency and who's calling. I mean, I guess if you pick up the phone and call as a patient, it could be a few months. I know if a patient, one of my patients that I know, or if one of the practitioners I work with calls me, I can get him in to see them next week. So, and if it's urgent, so it really depends on the urgency and kind of how they're getting to us. And so I think it's across medicine.
I will make a suggestion to those seeking to establish care. Set a scheduled appointment when you don't have anything scary going on. Try to just establish care and set that appointment up 6-8 weeks in advance. Go in, get acclimated, get all the testing done, and then you can push yourself to the front of the line when you have an urgent issue.
Yeah. The good news about this disease is, for the most part, these are HCM patients are generally, they may be sick, but they're generally stable, manageable patients. Yes, they have emergencies. Yes, there are things that happen that land them in the hospital, but a lot of the basic care of HCM happens on kind of a routine basis. So it's usually not quite as much of an emergency for routine care.
I would agree. And when you start getting things that are becoming more urgent, something's changing.
Yeah, so, and that usually requires coming into the hospital.
It does. We use the same philosophy here. Call us up and do your intake and navigation call when everything is boring.
Right.
So that when you're having a problem and you call and say, something's different, I need help, then we can just jump right to action and we don't have to do that precursor. So
I think it's a really good point that getting a patient in for an urgent visit who's already established with us, who we know, is much easier than trying to get an urgent visit for somebody new. Just because of the way things work. We also I'm trying to change up my scheduling to provide new patient visits a little bit additional time than our normal new patient visits, because HCM patients are oftentimes complicated. They may be stable, but they have a lot of complex things and a lot of things that need to be discussed. So I'm working with our schedulers to try to carve out a little extra time for every new patient.
Evaluating all of the potential issues that could impact not only the HCM heart, but the psyche and the well-being of the person and the family. This is where we're a bit different than some other disease states. So not only are you looking at the ejection fraction and making sure that it is fine, you're checking the valves, you're looking for arrhythmias, you're looking at diastolic function, you're looking at stroke risk, you're looking at sudden cardiac arrest risk, you're looking at the family history. There are a lot of individual components that we just kind of talk about and they roll off our tongue, but getting the data on those things, you need people to think, to
Yeah.
get organized, to share that information, because knowing why grandpa died at 40 is now important.
Right.
Was it a car accident where somebody hit him? Well, that's not his heart. Did he drive off the road? Was it a single vehicle accident? Did somebody just find somebody deceased in a chair and they don't know what happened? Those moments matter. And as you're thinking them through while you're in the doctor's office, you're thinking in lifetime, you're sharing in lifetime, and a lot of it is family myth.
Yeah.
So the more myth that you can dispel before going to your doctor, the better. So think about your family heart health history, what stories you've been told, which may not be accurate from a clinical point of view.
So
Agree or disagree?
get this all the time that the patient says, yeah, grandma died of a heart attack at 40. Well, tell me what that heart attack looked like. Well, she was found dead in her whatever, and so they said she had a heart attack. Well, that's not a heart attack. Maybe sudden cardiac death, and there's a big difference. So teasing out the history is really, really important, and it's one of the things we as HCM doctors, I think, spent a lot of time doing, is talking to patients about their family, both their family history and their children and their grandchildren and their siblings, and how best to optimize care for the entire family.
Fantastic point. So in terms of care for the family, what are your age ranges that you take care of at Piedmont?
So we are adult cardiologists, so I don't take care of children. We have a direct relationship with and a reference to children's healthcare. So when my patients with HCM have children, maybe who have turned positive for a gene, we strongly recommend they go to children's healthcare and engage. So we will pretty much see anybody over the age of 18. Rarely I have seen a 16, 17-year-old. If they're really adults, it's a little outside of my comfort zone, but pretty much we like to have them as adults.
So adults all the way up through geriatric,
Anything.
transplant, AFib, all of the things.
100 plus.
We hope.
Yes.
I had one that hit 100 that I know of so far. So it's not a big crowd. It's a small crowd.
Yeah, I think I have a couple.
With HCM.
Yeah.
Oh, okay. I know of, I can think of 2 actually now that I'm thinking about it. But most of these patients can live a longer life. And the data now shows, I mean, you're in the home of CDC down there. The Wonder database is a great little tool to slice and dice and figure out why people die and how they die and when they die. And over the years, we have seen that the life of somebody with HCM is extended out 2 more decades than it used to be.
It's interesting. I'm seeing a lot more HCM in older populations. I'm making the diagnosis more in 60, 70-year-olds, particularly 70-year-old women who are starting to kind of develop the disease. They never manifest it, and then it's showing up later in life. And I'm seeing a lot more of that than I used to. And I don't know if that's just because we're looking or because we're more aware of it, or some of our imaging is a little more accurate than it used to be. But I feel like I'm making a lot more diagnoses later in life than I used to.
I think there's a lot of reasons for that, and you're not the only one seeing it. Some of it is disease awareness advertising that's been out in the past 2 years that wasn't out before. And another piece of this is a lot of these women, when you talk to them about what's been going on over your life, the symptoms that they had, they're just like, "Ah, I got old and I got slow and I got this and I got that," when in actuality, they've been battling a disease that they didn't even know that they had. So now they're coming to diagnosis, which is great, and
Yeah,
we hope that more people get there sooner so that we can improve quality of life for all as much as possible, as early as possible.
absolutely.
But I do think I see what you're seeing.
Yeah.
We are. Okay. Well, that brings us kind of to the conclusion of a launch podcast, webinar, whatever we're doing here. There's all these different names now. And we are super thrilled to have Piedmont in the network. And again, Georgia, props to you because I do believe in terms of healthcare systems and insurers, we have the best coverage right now in Georgia than we do in, I think, any other country or country state. They feel like countries lately, all
Yeah.
independent little countries in our country. But Georgia has got really good, consistent care throughout the state, thanks to the trilogy of programs that are there. And as Piedmont has been added, getting down to the southeast has been a real win.
Yeah.
So, congratulations to Georgia and all of your partners. Congratulations to Piedmont and to you for going through this small
So
little process.
I also want to say thank you so much. You and your team have been fabulous to work with, and we look forward to a long, wonderful relationship with you. And it's been a joy to get to know you and everybody on your team. And it's been a great process, and we're proud to be able to use your letters and to work with you moving forward.
Likewise, so much so that we even invited you to come with us to Washington, D.C. in our Hill Day, and you got to give the doctor talk of what HCM is last week on Capitol Hill. So thank you for giving your time and coming up to the Hill at this very interesting time in our country's history. And make sure that the patient's voice is always front and center. We talked about some unique issues this year. We talked about generic drug quality, which listeners to our programming have been hearing about for a long time, but now we actually have some actionable items that we might be able to move the ball here a little bit.
Yeah.
Even though a lot of stuff is difficult and different, there are places where we can make improvements, and we can't miss any opportunity to improve access to care or to quality medication. So thank you for sharing your knowledge and your time with us. Truly appreciate that. Um, Curtis is commenting that his wife has HCM. Well, we can help your wife take care of her HCM, Curtis. So send them on our way. And if you live in the Georgia area, you might have a doctor right over here.
And
So
I know Stacy's kind of behind the scenes, but a special thank you to Stacy, because she, like my Rhiannon, who's helped me with this, have been instrumental, and without them, this doesn't happen. So a big thank you to Stacy and to Rhiannon in my program.
absolutely.
And
Stacey's backstage dropping links for us right now. If her camera quality was better, I'd bring her up on stage, but she's kind of grayed out because of some technical issues right now, so you can't see her. But Stacy is our Center of Excellence coordinator, and she has now been with us. It's like almost 3 years. And her being able to spend her time committed to developing these programs is why you're seeing more and more programs jump on board for us. Our list is not short. Our total list is there's 34 programs that are interested in HCMA recognition at this time. And there's about 5 of them that are on track for the next like 6 or so months for site visit and evaluation. So there's more coming. And they're throughout the country and, in fact, throughout the world. And the 35 are only the US based ones. So at this point, you are program 56, which happens to be how old I am when you got your designation. So
all right.
56 is the number this year.
Okay, good.
And there we go.
I would be remiss if I didn't also send a thank you to a couple of specific people in my program. Denise Reedus, my nurse practitioner, who's been working hand in hand with me, and without whom I don't think I could manage my patients. My nurse, Robin, who is growing into a great HCM nurse. And as I mentioned, Rhiannon, who has been instrumental in building all the structure and helping me build the structure of the program.
Well, she's done a great job coordinating all the administrative aspects, and we thank her too. And it was delightful to spend some time with her when we came to Atlanta for the site visit, which was, we did that during an interesting time too.
Oh, yeah, during the storm.
During the
Yeah,
hurricane.
the hurricane, right.
No big deal. We'll do a site visit during a hurricane.
Interesting his story. We've had at least one HFSA that was blown out by a hurricane this year.
I was there for that too. And then I went to Florida,
right.
and then I came back for your site visit. It was a little chaotic, but we did it.
Yeah.
We do have a question coming from the audience.
Okay.
For the footage, we can kind of cut this for your directory listing. But Nikki or Mikey, I can't quite make that one out, has a question, and I have bad eyes, so I have to put the glasses on before I can read it. Is dizziness common with, I love this acronym, HCM? So I'm assuming she has an apical, or he has an apical presentation. Do you want to talk about dizziness as a symptom while we have them here?
That's a good question. We typically will see dizziness a little bit more with obstructive form of HCM. However, any form of hypertrophic cardiomyopathy can be associated with certain heart rhythm problems, and some heart rhythm problems can cause dizziness. So it's imperative to look into multiple different causes of dizziness to make sure that either there's no obstruction or there are no heart rhythm issues that go into the cause.
I will add, from a personal perspective, when I went in more to an end stage area, that I was dizzy a lot.
Yeah,
that was my biggest symptom.
When you're dealing with issues of low blood pressure, which is probably where you were at the end stages.
80 over 45.
That can definitely cause dizziness. In the earlier stages, we do see people have exertional dizziness when they get obstructive, and their blood pressure drops because the gradients go up. And we see it mostly with arrhythmias.
So, Mickey, dizziness is part of HCM. I know a lot of times community cardiologists will say things like, well, that's really not an HCM symptom. Dizziness, shortness of breath, lightheadedness for some people. Chest pain for women could be in their shoulders, neck, or center of the back. It's not going to be in the front and radiating down an arm. So pay attention to what signs your body is sending you, and feel free to communicate all of the symptoms that you're feeling with your physician. You're not complaining, you're reporting, and it's okay to report. And women should report more often, because we tend to go, I'm okay, I'm okay, I'm okay. The men do it too, but the women do it more. So talk about your lived experience and let your doctor understand what you're dealing with so that they can help you appropriately. Simple as that. All right. Ken, thanks for taking the extra question with us. Thanks for joining us today, and we look forward to the continued relationship. Thanks to the entire team, and congratulations for joining our network.
Thanks so much. It was a pleasure.
Thank you, everybody, for joining, and we wish you a happy holiday weekend.